Footprint of brain cell damage, from diabetes through hypertension to brain cell calcification, number 1354, September 11, 2025. Gerald C. Shu, EclaireMD Foundation. Category: Diabetes, Hypertension, and Stroke. Preface. In the afternoon of September 11, 2025, I met with Drive Neil Schwartz, chairman of the stroke department at Stanford University, for a follow-up on my stroke and to review my CT images and MRI films. For the first time, I clearly understood the underlying reason for my recent hemorrhagic stroke. It was not a single trigger but the cumulative outcome of more than 3 decades of type 2 diabetes, intermittent episodes of acute hypertension. Even though my medical records never listed me as a chronic hypertension patient, and the visible white calcifications within my cerebral small vessels, over time, this combination gradually weakened the resilience of my brain's microcirculation, until one vessel could no longer withstand the stress. This realization aligned closely with what I learned in Professor Jones's MIT classroom in 1972, about nonlinear plastic responses of structures under dynamic loading, diabetes and its long-term vascular effects. I have lived with type 2 diabetes, T2D, for more than 30 years, although the past 15 years were marked by strict and disciplined lifestyle management, and relatively good glycemic control. Hemoglobin A1C within the range of 5.8% and 6.7%. Without any medications, the earlier 2 decades of poor control left an imprint on my vascular system. The medical literature is consistent on this point. Chronic hyperglycemia promotes endothelial dysfunction, arterial stiffness, and accelerated atherosclerosis. The pathophysiology involves several mechanisms. Persistent high glucose leads to the accumulation of advanced glycation end products, AGEs, which cross-link with collagen and elastin in the vessel wall, making arteries less elastic. Hyperglycemia also activates oxidative stress pathways, generating reactive oxygen species that directly injure endothelial cells. In addition, T2D is associated with chronic low-grade inflammation and dyslipidemia, both of which destabilize vascular integrity. The net effect is progressive injury to small and medium arteries and the laying down of calcium within their walls. Hypertension, chronic, and episodic damage. Hypertension is the other key player in cerebral small vessel disease. Sustained high blood pressure increases shear stress on vessel walls, thickens the intima media layer, and accelerates calcification. Yet in my personal case, I was never formally diagnosed with chronic hypertension. At first this seemed contradictory. How could my radiology report point to hypertensive calcification? The answer lies in what medicine now calls masked hypertension, or episodic surges. Many individuals with diabetes experience blood pressure elevations that occur at night, in the early morning, or during periods of emotional stress. Besides, right after exercise, it is possible to experience acute hypertension, especially in people with diabetes, vascular stiffness, or small vessel calcification, because blood pressure can rise sharply and sometimes remain high instead of returning quickly to normal. These are seldom recorded during office visits, but may be detected with 24-hour ambulatory monitoring. Evidence shows that such episodic surges are not benign. They generate mechanical injury to small arteries, particularly in the brain, where auto-regulation of blood flow is highly sensitive. Over decades, these transient surges accumulate damage, equivalent to that caused by sustained hypertension. Imaging evidence: Connecticut and MRI. My own CT scan revealed scattered bright white deposits along some small cerebral vessels. Classic signs of vascular calcification. CT is the modality of choice for visualizing calcium, as it detects high-density deposits with excellent sensitivity. MRI, on the other hand, did not highlight the calcium directly, but demonstrated the consequences: white matter hyperintensities, small lacunar infarcts, and evidence of chronic microvascular disease. These findings are consistent with what the literature defines as cerebral small vessel disease, CSVD, a leading cause of both ischemic and hemorrhagic strokes in elderly patients. Radiologists often attribute such findings primarily to chronic hypertension. Yet my own case shows that long-standing diabetes and aging can produce an indistinguishable imaging profile. With more than 3 decades of diabetes and an age of 78, the presence of calcification in my cerebral vessels is entirely plausible, even without documented hypertension. Additional contributing factors, beyond diabetes and hypertension, other elements of my medical history, add weight to this outcome. Aging alone stiffens vessels by altering elastin and collagen composition. Chronic kidney disease, CKD, which I have experienced, disrupts calcium phosphate metabolism and accelerates vascular calcification. Dyslipidemia, another frequent companion of diabetes, promotes atherogenesis and vascular inflammation. Thus, when multiple risk factors converge: long diabetes history, silent blood pressure surges, aging, CKD, and dyslipidemia, the brain's small vessels bear a relentless cumulative burden. Eventually, The structural integrity of a vessel fails, and in my case, the failure manifested as hemorrhagic stroke. Integrating science and personal experience. From a scientific standpoint, my case illustrates a typical math-physical example of the nonlinear, dynamic, irreversible, and cumulative nature of chronic disease. Traditional medicine often focuses on single risk factors, measured at a given point in time: hemoglobin A1C for glucose, systolic blood pressure for hypertension, LDL for cholesterol. But vascular calcification is not the result of a single lab value or one clinic visit. It represents the irreversible outcome of decades of multiple interacting stresses, biochemical, hemodynamic, and metabolic. This cumulative effect can be clearly demonstrated using the viscoplastic energy model. VMT. See my other VMT papers on journals or YouTube channel, provided that relevant longitudinal data are available. From a personal standpoint, I now recognize that my stroke was not merely bad luck, it was the predictable end product of the stresses carried by my vessels for more than 30 years. Even though I have worked diligently in recent 15 years to control my diabetes, the damage from earlier 2 decades remained embedded in my vascular system. The calcifications visible on my CT scan are, in essence, the scars of my past physiology. Clinical relevance and lessons. What can patients and physicians learn from this? First, calcification of cerebral small vessels is not just an incidental radiologic finding. It is strongly linked with cognitive decline, white matter disease, ischemic strokes, and intracerebral hemorrhage, ICH, a subtype of hemorrhagic stroke. Its presence should be regarded as a high-risk marker, prompting comprehensive management. Second, management must be multifactorial. Strict glycemic control is essential but not sufficient. Blood pressure should be monitored beyond clinic visits, ideally with home or ambulatory devices to detect hidden surges. Lipid levels must be kept in check, kidney function preserved, and lifestyle elements such as sleep and stress systematically addressed. Finally, my experience underscores the importance of adopting a systems-based perspective in medicine. Chronic diseases like diabetes and hypertension are not independent silos. They interact dynamically to shape outcomes over decades. Cerebral small vessel calcification is the physical embodiment of that interaction. My earlier paper number 1350, which applied wave theory from physics to compare high-frequency blood pressure waves with low-frequency glucose waves, provides insights into this phenomenon. High-frequency blood pressure surges with large amplitudes, acute hypertension, can rupture a vessel, while low-frequency hyperglycemic waves persisting over decades cause cumulative and permanent damage to blood vessels, including those in the brain. Conclusion: as I reflect on my CT and MRI scans, I no longer see them as static pictures but as the story of my life with diabetes and vascular risk. My recent stroke was not caused by a single event, but by the cumulative and integrated effects of my type 2 diabetes, episodic hypertension, vascular calcification, and aging. For patients with long diabetes histories, the message is clear: manage glucose, yes, but also monitor blood pressure with vigilance, control lipids, protect kidney health, and respect the roles of sleep and stress. For clinicians, the lesson is to look beyond single numbers and adopt a holistic, longitudinal view of vascular health. My stroke has taught me that every year or decade of disease matters, and every day of management counts. The brain does not forget our past physiology. It carries the memory and the calcium embedded within its vessels. Appendix, VMT statement. The viscoplastic energy theory, VMT, is a math physics framework that models disease as cumulative, nonlinear, time-dependent, and irreversible, the same principles that govern material failure under stress. It provides a dynamic systems approach for understanding health outcomes beyond the limits of statistics. For VMT details, please search Health Talk with EclaireMD on YouTube. Disclaimer: this content is for educational reference only and not medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be edited or republished as your own.